A very good afternoon, ladies and gentlemen, and a very warm welcome to all of you. I'm your virtual host, Diksha Rana, and it's my pleasure to welcome you all to this eventful afternoon at AIOC 2021. So, ladies and gentlemen, to begin with the next session of the day on J&J Technology session, I would now like to invite Dr. Ramamurthy to please moderate the session. And on the expert panel, we have Dr. Debashish Bhattacharya, Dr. Gaurav Luthra, Dr. Virendra Agarwal, Dr. N.V. Arul. Over to you, Dr. Ramamurthy, sir.
Thank you. Thank you so much. And really a pleasure to meet up with friends and have this useful afternoon discussion. Thanks to J&J for putting this together. I see we have some stellar ophthalmologists doing cutting-edge technology involved in this session. I'm sure this will be a very educative, informative session. And it's indeed a pleasure to have Dr. Arul with us as in the expert panel. Debashish, Gaurav, and Virendra should be joining it shortly, but we have the speakers here, so we'll get going. And it's my pleasure to invite my good friend Kumar Doctor to be speaking on role of technology in delivering better patient outcomes. I can't think of a better person than him to handle this. He's situated in the Star City, a star himself, and have been doing cutting-edge cataract and refractive surgery for more than 2 decades and being very successful at it. Over to you, Kumar.
Thank you, Rama. It's always a pleasure to be with you. So I'm just going to talk a little bit about how technology should help us. But before I start this, I truly believe in this, that all doctors must understand that they are premium. First, we must learn to value our skills and our abilities, and we are more premium than the technology that we use. So this is my first statement, and I want everyone to understand this. Look at this. The grandfather calls up the little child and says, "Grandpa or grandma, it is not that so hard. Go to settings, select Wi-Fi, and then tap with your finger." And the grandfather asks him, "Which finger?" And he gets irritated and says, "Please use any finger to get enrolling." So what is it dividing the talk? That whole talk I'm going to divide at different levels. The level of the OPD, level in the OT, knowing your IOL and its performance, and when to know what to do and the high risk in tough cases. So it's a long talk, but I'll try to finish fast. So today's day, essential tools. Once upon a time, Pentachem, optical biometry, image-guided surgery, femto, corneal wavefront analysis, and OCT were not a necessity. They were considered to be a luxury, and they were considered to be having only institutional-based practices. Unfortunately, this is today a necessity. So according to me, one should ban contact biometry. So if you have an ultrasonic biometer, please do immersion. And of course, if necessary, you can get an optical, that's even better. Have imaging tools if necessary. You must have access to all the IOL formula, and that will help you to get better results. In the operation theater, you need a better operating microscope, because if you see well, you operate better, you perform better, the results are better. Imaging system for cataract surgery, if you have, it's even very good. I'll tell you why. A femto cataract, if you can get, it is better. A high-end phaco machine, because it has its own benefits. And of course, if you have an online biometry that is there today, it's called Orange. It can be connected to a microscope with better instruments. Once upon a time, I used to say have sharp instruments, sharp knives, a good hydrodissection cannula, but now the steps are better. So you must know your IOLs, you must know your monofocals, multifocals, different refractive, diffractive, apodized designs, and torics. And you must also know the placement of the lens that has to be in the bag, and different ads that are available in the market with different IOLs, and how to mix and match. So yes, as far as the IOLs are concerned, the 2 best IOLs today that I think that are available in the market is the no financial interest is the iHance, and of course the Technis Symphony, and now the new Synergy. The biggest advantage of iHance is that there's no loss of contrast, there are no glare and halos, and patient can do the routine work without glasses and dependency on glasses. So WhatsApp, email, iPad, mobile can be done without. Of course, you want to read small print, you need an ad of 1.25 or a 1.5, and patients are extremely happy because there's no rings and no halos. Symphony gave excellent intermediate result, but needed a little ad But again, not much loss of contrast. And that was but some symphony patients did complain of glare and halos. So knowing your depth IOLs is very, very important, whether it's a trifocal or it's a bifocal or whatever lens you want to use, knowing how the IOL performs and knowing how the patient is going to behave. You must also know your SIA, that is your surgical induced astigmatism, and if you can calculate your personalized A constant. Then came the introduction now of the J&J Synergy IOL. So what they have done here is they have combined the Symphony with a multifocal. So the biggest advantage here is that your patients are able to see distance, they can see intermediate, and they can see near. So technically it's like a trifocal because they see all the distances, but at the same time, the amount of glare and the halos complained by the patients is bare minimal compared to a normal trifocal IOL that you will get in the market. So this is how the lens rings appear on high magnification, and that is how it is. There has been a big evolution in surgery as far as incisions, viscoelastics, technologies, lasers, and all are concerned. But here I'll just tell you about how the incision, I don't know, Dr. Ramamurthy would know about this. The original, we used to have stainless steel incisions, then came the ruby and the sapphire knife, then came the black diamond, and now comes all the sharp instruments that we have today. Then comes to image-guided surgery. You can see that the incision is made exactly where cyclotorsion is looked after. This is quite important if the patient has a high cylindrical number. If not, here I'm trying to mark the cornea, and at the same time, what we do a manual marking and a rhexis marking that comes from image guided, and you can see that exactly a CCC can be performed accordingly. And this is the alignment that you can get. So this is at 16 degrees placement of an IOL. This is very, very important because when you mark manually, sometimes it may be 15, sometimes it may be 14, but this gives you very perfect placement and perfect marking. How else has technology helped us is the femto laser, and I truly believe in the catalyst now. I've been using it for more than 5 years. It can do a rhexis in less than 1 second, which is very important in phacomorphic or subluxated cases. It does fragment and actually makes a pulp out of your nucleus, so your phaco energy time goes down significantly. And this is one case where a patient had a subluxated cataract. You can see the subluxation, and I made my rhexis, but there is no donesis. So here I go ahead and do put the capsular hooks, and then the beauty here I feel in the femto is that the fragmentation is beyond the rhexis, which will never happen normally. So here go ahead and do your phacoemulsification, put the endocapsular ring, and then put in an IOL. And this was all very easy possible only because of the femto technology that we have. This is another case, a subluxated IOL, a young patient, traumatic subluxation. I went ahead and did. This was my first case, unfortunately. I made a very small rhexis. So you will see that that was my inexperience, but here you can see a tilt that is there of the lens, natural lens that is there because of the subluxation. I go ahead and make a small rhexis away from the area of subluxation, and that small rhexis is almost of 2.9 millimeter. Don't worry, friends, I'm going to show you the surgery. You will wonder what am I doing with a 2.9 millimeter rhexis, but there are two take-home messages here. So this is the fragmentation that has happened, and now I'll show you the case directly because of paucity of time. So this is a 2.9 millimeter rhexis. We have an inferior subluxation. There are two very important take-home messages here. One is you can fragment very easily. You can, this was a young patient, an 18-year-old. So I just needed a bimanual IA. I really didn't need any phaco energy. Went ahead and removed the whole cortical material and the lens material. And you can occasionally see that sometimes the posterior capsule or the anterior capsule wants to come with the cortex, but with easy patience, a little bit of patience, and stripping all of the cortex comes off quite well. Go ahead and put in an endocapsular ring. Once the endocapsular ring is placed, I go in and put an IOL. Now, very important take-home message with this is wherever your rhexis is, the IOL will center in the center of the bag, irrespective where your rhexis is. So you can have a decentered rhexis, but the IOL will center in the center of the bag that is there. So this rhexis, of course, ultimately has to be extended. Otherwise, the capsular phimosis will really cause problems. And this, we go ahead and make the rhexis a little larger. So femto in a subluxated case is quite possible. The femto in a small pupil, this is just a case to show you that there was a small pupil. I put in a Malugan ring. This was also a subluxated cataract. I went ahead and did the femto quite successfully. So just a hypermature cataract and femto, again, as I said earlier, we don't try to do fragmentation of the lens material, but here I'm going ahead, and you can see here that once I made my incision, you will see that I go ahead and just remove the center capsular CCC that is done with the laser itself. It's nice to stain sometimes, and there's a mistake I made. This traction that you're seeing is subcapsular. So the capsule itself was free. It is subcapsular, but it came off very well. So to get a perfectly round, nice CCC in a hypermetro cataract is quite possible in femto technology. In hard cataracts today, we can have sectors with cubes and cubes extra. That is the biggest advantage here is this, that you can program your whole system to do whatever it wants. So this is how it looks, that you can have small cubes and sectors. It actually makes a pulp out of your hard cataract. And it is very well scientifically proven that the phaco energy that is necessary in soft cataracts, in hard cataracts, when you divide like this is quite easy. It actually reduces your phaco energy to 50% of the normal phaco energy that would be required. Now, this is a symphony toric that you're seeing here, going ahead and doing the the phacoemulsification, and then just the placement of the lens in 84 degrees. A symphony toric gives excellent distant vision and excellent intermediate distant vision. We can mix and match with this. So you can put a symphony in one eye and a synergy in the other eye, and patient will be still very happy. The synergy takes care of your reading to N6. Symphony takes care of your intermediate. Remember that I would prefer to put the synergy in the near dominant eye and the symphony in the distant dominant eye. So this combination works extremely well with aided of technology of image guided, with aided of technology of femto. It gives excellent centration of the IOL. You must have your capsular axis surrounding the optic all around. We know this. That prevents the lens from decentering at a later date. Now, high-end machines, I just want to show you, this is a very old video where I've kept the vacuum at 650, which is the highest, flow rate at 60, which is the highest, and the power at 40. Just to show you a few seconds that look at phacoemulsification, holding the nucleus, chopping and dividing, and look at the vacuum going to 550, 560, and yet you don't see any surge. So you can drive a Ferrari with an airbag. In case you have a problem, it will protect you. So this is like driving a Ferrari at 650 vacuum, 60 flow rate, no surge. This is a grade 1, grade 2 cataract, and absolutely stable anterior chamber. So that helps you. Just the last case here where a patient has undergone RK. We don't get image guided images here. I'm doing phacoemulsification, quite easy to do that. Luckily, I had enough space because this was an 8-cut RK. Here I'm going ahead and putting in a toric IOL, which does very well with these patients. So you can see the manual marking, and I'm aligning the lens. I love the Technis toric IOL because it sticks to the bag, it goes down and sits. There are some lenses which actually, when you put it in the eye, and if you saved it in the air-conditioned theater, it will not unfold easily, and it takes a long time to unfold. And then when you put in irrigation aspiration, it tends to rotate. I love the Technis because once you place it in, it just goes in, aligns itself, and it never rotates. It sticks back. And we have hardly, I mean, in so many years, I've never rotated a Technis toric IOL at all. So this is an RK operated patient. You can see the alignment, manual marking, and 8-cut RK. Sometimes these wounds do open up. If they do open up, nothing to worry. Just take a suture and it will be all set. So I am personally of the belief that in difficult cases, know your IOL, know the technology that you're using, know the multifocality that you want. If you have image guided, then it is best thing to do. In summary, technology invented by humans is a huge aid for better consistent outcomes, for better results for our patients. So don't forget that we are the doctors. Thank you very much. And thank you, J&J, to have asked me to participate in this symposium.
Thank you, Kumar, for that great presentation. What Kumar is to Bombay, Arul is to Chennai. Over to you, Arul, for your expert comments.
Yeah, Kumar brought out all the new technologies that are very useful, and he also made a very profound statement. 5 years ago, or maybe even less than a decade ago, technologies that you thought were icing on the cake and they really didn't matter, you could live without them, have become the most important part. Now, optical biometry is just not making things more accurate by getting an accurate axial length alone. K values are far more accurate. You get anterior chamber depth, you get white to white, you get lens thickness. Number of these parameters are necessary, and the best formula is needed to get the best results. So all of them are put together, and you can't do an advanced lens without checking the macula. So OCT become necessary. So all of these tumble down into high technology is becoming the standard methodologies now. We have to catch up. or share the technologies with people who don't have access to it. It should be shared, and this should be available to every single patient who wants to get the best out of their systems.
I think that was an excellent overview, Kumar. I mean, a great introduction to the series of talks that's to follow. I really hope that you stay back and continue to contribute. And
Yes,
just one specific question, because you covered almost the entire gamut of modern cataract surgery. I'm a little wary of putting in a toric intraocular lens in a post-RK case. I mean, what are the precautions that you took in that case?
sir, I've used a lot and I'm very happy. Only if it's a very big bag. Because if it was a very high myope and who had undergone RK, then these lenses are not enough length. The only additional precaution I take sometimes is to put an additional endocapsular ring. So if we put an additional endocapsular ring in a high myope who had undergone RK, we have videos like that, and then that will prevent the lens from further rotation or decentering. So this is one thing, but I have got excellent results because the cornea is equally flat from the anterior surface and the posterior surface, and they're very happy. Another thing, they tend to compare the vision with what it was pre-op. So they're anyway very happy because their cylindrical is gone, and even if they have a little correction, they really don't care about it. So I have found it with excellent results, and the patients are extremely happy.
Very good. No, obviously, the surgery in a post-RK is not really a challenge as far as you're able to avoid the incisions. It's more the decision as to what power to put in. One dictum that I follow in all these cases, whether it's post-classic or even more so in post-RK, the patient has been happy with their glasses correction outside. Then putting in because the lens that you put in is not going to do anything to the higher order aberrations or quality of vision. If that was lousy and they were not happy, putting in a lens is not going to, toric lens may not help. But they had an orthogonal astigmatism and they're quite happy with the cylinder in their glasses. Then maybe when the cataract comes up, doing it might be a good idea. Gaurav, Virinder?
I recently, last week only, I put one toric IL for a high-powered post-RK eye. In fact, I did both eyes. First eye, I did not put it because of the same reasons. That patient had almost 8 diopters of astigmatism in both eyes. In the right eye, which I did first, there was no agreement on the axis between the various methods that I was measuring with. With the second eye, I got very good, agreement with them. And plus, on the EKR report, I saw that over the optical zones, the axis remains more or less constant. So that's another way of making sure that. So I was able to cut down his astigmatism from almost 10 to 5, and patient is very happy in the second eye, unaided 618 almost. And so some places it will work really well, and others you have to be careful. If there's no consistency in the readings, and as the other factors that you just spoke about, you have to be very, very careful about it.
Thank you, Gaurav. I think now we'll move on to the next presentation. Dr. Pooja will be joining us a little later, so it's my pleasure to invite Dr. Mohan Rajan to talk about tackling hard cataracts with flax. He's another flamboyant surgeon, and there's so much we learn from listening to him. He not only teaches it, but amuses us also, but manages to slip in a lot of education amidst all the excellent command that he has. Over to you, Mohan.
Able to see my screen, Ramurthy?
Absolutely, absolutely.
Thank you very much, Ramurthy, for the nice introduction, and also the fantastic panel here. Thank the J&J for this wonderful opportunity and the wonderful symposium as well. These are my financial interests. What are the keys to the refractive cataract surgery? You increase your refractive accuracy, but good biometry, address the astigmatism, decrease the complications like avoid capsule issues like corneal edema or cystoid macular edema, choose the best quality, visual quality IOLs, and exceed the patient expectations, under promise and over deliver. Hard brown cataracts, as you know, is a challenge to the phaco surgeons because of the difficulty in the posterior nuclear plate. That is a difficulty to crack the nucleus because of leathery attachments, thin posterior capsule, large nucleus, poor or no cortical cushion, increased incidence of corneal edema and post-operative corneal decomposition, increased incidence of PCR and nucleus drop as well. So you need to combine the technology and the technique, and that's what is the basic aim of the symposium, how we combine the technology and the technique. And the technology is available in the form of really all the phaco machines like Signature Pro, the Centurion, or whatever, Infinity, and the Stellaris, whatever it is. So you can see this brown cataract. It's like a piece of granite inside the eye. And make sure that the corneal endothelium is very good in these patients. A lot of protocols you need to do, have a careful pre-operative protocol before we do this patient. If you have do the conventional phaco, sometimes you can end up in a corneal edema like this, but may clear up in about a month or so. But the problem is, this corneal edema can be associated with a lot of prostaglandins or what inflammatory cytokines being released into the eye, and something like this, what is called the toxic anterior segment syndrome, or the fibrin reaction, which is there on the surface of the IOL. And 25% of the corneal edema can have a problem in the retina, which is called the cystoid macular edema, which may be sometimes very refractory to treatment as well. And these are the post-operative pictures. You can see the femtophaco, the clear corneas as well. Just to show you how I do the conventional, the technique of the manual phaco in a hard brown cataract. I always do a rhexis, which is about 5.5 millimeter, not more than 5.5 or 5.6 millimeter approximately. I don't want the rhexis to be too small. I don't want to be very big. I want the rhexis to be a little on the larger side because I need the space for my chopper. You can see here I'm doing this. These are the parameters I use on a Stellaris PC machine. I use my chopper there, the sharp chopper. I can see here how much of phaco energy I have to do this to open up the posterior nuclear plate. Every time I dip into the nucleus, I need to use phaco energy, which means that there is a certain amount of heat which is delivered into the corneal endothelium. And every time I dip into the nucleus, I need to open up the posterior nuclear plate, which is going to and you can see the effective phaco time is almost 25 seconds. What is happening in catalyst? Manual phaco is something like the Sachin. The Sachin is good in one format of the game, whereas Dhoni is good in all formats of the game. Okay, whether it's T20 or one day or the test match, because that is where I think the catalyst of the femtophaco plays a role, because the entire spectrum of cataracts, whether it's hard brown cataracts, subluxated cataracts, posterior polar cataracts, even for soft cataracts, I would recommend this, because patients coming with very good vision, you want a safe surgery. The vertical spacing I would reduce by about, in hard cataracts, about 25, and grid space, horizontal, we don't do this, the softening of the cataracts. The pulse energy is about the same. The rock hard cataracts, I do the vertical spacing much less, which is about 20. And normally in the softer cataracts or the medium cataracts, I do about 40 vertical spacing. Here I do 20 because I want the what you call the openings to be, or the spots to be closer to each other. You can see this is a hard cataract, which I'm going to do. I'll just quickly go through some videos here, wherein you can see here, this is a fairly hard cataract, and you can see the rhexis is already done. One of the biggest advantages, I think Kumar beautifully mentioned that, is that there is a cutting of already it's pre-cut. It's like a pre-chopped nucleus. So I'm just using a Sinskey hook there to open up this, the entire posterior nuclear plate, because already the posterior nuclear plate is opened up. I just have to you can use any instrument for that matter. The Sinskey hook is more than good enough. You can see here how it is there. And I don't use much phaco energy. I just go there, dip there, and open up the posterior nuclear plate, and the entire thing comes out. And we have excellent missions with fluidics like the Centurion or the Stellaris. The followability is very good. You can actually stay there, and automatically all the pieces will keep coming to the thing. Now and then I inject Visco. This is a routine in all my brown cataracts to make sure that my corneal endothelium is well protected. So just to show you this, another patient with a little more brown cataract, you can see it's a grade 4-5, very dense brown cataract. Invariably, I make the main incisions in almost about 50-60% of the cases, unless the patient has got a dense arcus inless. Side port incisions I don't make, but this is just an early case I just want to show you. But the incisions also, I want to make sure that the incisions are good incisions for me, but do these hard cataracts, because the triplanar incisions are very important. Don't do too much of hydrodissection. Already certain amount of gas dissection is there, and make sure that, because sometimes you can have an hydro rupture. You can see how these cataracts open up very beautifully. The very fact that the gas bubbles are coming from the front to the back, it means that the posterior nuclear plate is already opened up. So you can go bevel down, bevel sideways, bevel up, whatever you're comfortable. You don't need to do any trenching. That is the advantage of these cataracts of this thing. You open up this thing, and the opening of the posterior nuclear plate is the most important thing in these hard cataracts. Once you open it up, you can easily gobble up these cataracts without any problem at all. I can see that I'm just separating the central one, and the rest is very, very easy for anybody. Okay, you can just stay there and even close your eyes and operate. That is one of the things which you can do. Again, you can see here another patient with a femto black, almost brown black cataract. You can see here the rexus is taken. I always use a making sure that it's free floating rexus, and just sometimes you do a small trench, but it's not necessary invariably, and you can open up the nucleus without any problem at all. And whether you use a sharp chopper, I use normally a sharp chopper, the Mohan Rajan chopper made by the Appasamy. I don't have any financial interest in that. Just to open up the posterior nuclear plate, because I already opened up the pre-cut, the pre-chopped nucleus is already there. Just to show you of cornea, dense cataract with the cornea gutata, 1000, the count is there. I'm putting a toric lens and can see here how this surgery proceeds with the femtophaco. Absolute indication for a cornea gutata or a fuchs endothelial dystrophy with the dense cataract is this, because you do have very, very less phaco energy and the corneas are fairly clear and you don't have much loss to the endothelium as well. So I'm using a Centurion machine here and just doing this thing and just chopping. I'm using a similar the chopper, the regular chopper as well. I can see that already the cut is made. I just have to open up that. I just have to hold the right side of the nucleus and open up in the crevices which are already made. I can see the gas bubbles are coming up, and the rest is very, very easy. Just to show you that you can even open up the entire this thing with even a Sinski hoop, just to show you. This is a femto after this very bad sick cornea, 2 hours, and after 2 days also you can see that the cornea is crystal clear as well. Just to show you in black cataract, okay, many people say, no, don't do even phaco. But the problem is, the advantage of the femto is that in black cataracts, dense brown cataract, you can see that I'm doing a trenching here. I'm doing a manual phaco. You can see the amount of phaco time is about 33 to 35 seconds in this particular case. But how every time I have to go inside, I have to penetrate or bury the phaco tip. I expend some phaco energy and I have to open it up. I have to do lateral separation. I have to go all the way down, whether they use a sharp chopper or a blunt chopper, whatever it is, that every time, and the surgical time is also a little more. Just to show you this hard cataract, which I did live surgery in the surgical strikes last year with the catalyst, and the almost a black cataract, you can see here how it is easy for you to open it up. See, because I did do the octants, that is the 8 quadrants in these cases, and you can see how it is opening up very easily. Not much phaco energy. The phaco energy is only approximately 12 seconds, the entire effective phaco time. The amount of phaco energy is very, very less. The amount of surgical time is also very less because already it is pre-cut and you just have to go inside and do the. I'm using a Signature Pro machine in this particular case and can see the followability is really fantastic. I think Kumar has beautifully mentioned about the features. These are all the various brown cataracts you saw and all the post-operative pictures. Crystal clear cornea, the pristine wounds, no corneal burn. You can see here no corneal burn, pristine wounds in day 1 without any problem. Again, white cataracts also, the Argentina flag sign, the intermittent cataract is a huge problem. And this is a 100% what you call foolproof method, I would say. Femto cataract, you can go ahead and do this thing without. Only thing is, when you are doing a rexus in a femto rexus in a white cataract, look for skip lesions. Don't try to pull the capsule out like the way we normally put, because normally it's a free floating capsule thing. In a white cataract, look for skip lesions there and make sure that you are, otherwise you can end up in tags which can extend to the posterior capsule as well. Many people say this is just to show you that.
Can you conclude, please?
Yeah, I'll wind up with it. Yeah. Take home message is flax is in complex situation. White cataracts, hard brown cataracts, posterior polar cataracts, subluxury cataracts, fuchs endothelial dystrophy, and corneal gutata. All these complex situations are very reduced surgical time, reduced effective phaco time, more precision, clearer corneas, and reduced complications, safety, precision, bladeless, consistency, wow effect, good platform, differentiates the practice from other practices as well. Thank you very much for the wonderful opportunity again, the patient attention.
Thanks a lot, Mohan. You almost covered the entire spectrum of difficult cataracts. It's my pleasure to introduce Dr. Bobby Ang. Are you there, Bobby?
Yes, I'm here.
Oh, great. So from Philippines, a very good friend and internationally renowned ophthalmologist, contributing not just in the Asia Pacific region, but on the world stage too. Thank you for joining, Bobby. Great to have you.
Welcome, sir.
Hello, thank you. Can I start
Any
now?
comments on Mohan's presentation from you, Bobby? I mean, do you use the Femto platform, the catalyst for the hard cataracts?
We have our own Femto for hard cataracts. Yes, I'm very impressed with all his videos. You know, Mohan is like a superstar. I'm not so brave with the black cataract though, because I know that even if I pre-cut the cataract, there's a lot of phaco time to deal with, and I encounter corneal edema. So I put my limit to a brunescent dark brown, and I usually do 4 cuts, and then my style is to groove a little bit, and then to separate laterally each of the 4 quadrants. I find that technique useful because I've been doing like a divide and conquer technique, but I'm very impressed with his videos. Very impressive.
Thank you, Dr. Ang.
Great, Bobby.
It's always a pleasure.
Virender, would you like to comment? Dr. Virender?
He's muted.
Okay.
He's taking a nap.
Okay. Gaurav, you can.
No. So there were spellbinding videos, Mohan sir. And yes, for my very hard cataracts, I would use this as my method of choice. Wherever you can crack them. Of course, opaque cataracts you can't do much, but I think it's a big benefit because you can get the right size rhexis. You need an adequate rhexis, and you can do the brown cataracts quite well because it does cleave them. I usually make 6 pieces out of it, and then try to do proper lateral separation and work it out. Of course, hard cataracts you still have to kind of make sure that you're using all your other skills of lateral separation and cracking as well. You will not get it will not obviously cleave them all the way through, but big value addition.
Can I add one point?
I do it slightly differently in the sense that this what Mohan showed, of course, fantastic videos, and it works very well in his hands. Over time, what I've started doing is with the 200 grit spacing, extremely small cubes, I emulsify the entire cataract with just leaving a 500 micron offset from the posterior capsule, and then create a small groove in the subincisional area with my phaco probe. Then do the conventional chop and go ahead. I find that once you have used this 200 grit, it almost reduces the hardness of the cataract quite significantly. A grade 5 cataract may behave something like a grade 4 or a grade 3 cataract. Of course, in slightly lower grades of cataract, I combine it with a segmentation softening and then go ahead. The really hard cataracts, I follow a slightly different strategy.
I used to do that, sir, if I may answer, but I've, over the years, I've gone on to this one because, 1 or 2 times I got those very small fragments of, those cuboids, going away into the sulcus and remaining there and leading to post-op inflammation. And ever since I've been a little wary of this, but otherwise, yes, it softens the cataract really well, but I've gone back to using the 6 quadrants. I don't know.
Another thing is when you soften the cataract, you lose the red glow. That is the reason why I'm not softening the cataracts nowadays, and also to increase the femto-phaco time. That is the femto energy time. So I normally don't keep it beyond 90 or 95 seconds. So beyond that, I don't keep it. So because these cataracts are very thick cataracts, about 5-6 millimeter in thickness. So that is the reason. And another thing I want to say is that the common misconception is that in mature cataracts, it doesn't go inside. In near total mature cataracts, as long as the OCT is able to recognize, because we have seen, I had a video, but didn't have because of paucity of time, I couldn't show it. You can actually, the femto goes inside and cuts the cataract as well. So it does the cleavage of the nucleus, even in a near total cataract after doing the rhexis.
Thank you, Mohan. White cataracts where it doesn't work, and anything brown, it works. And we need to pass on.
Yes.
Can I just add something there, Ramurthy?
Yes, sir.
Comment, please.
Yeah, just what Mohan said, except for an absolutely white opaque cataract, really dense black cataract, the laser does penetrate and soften the nucleus. And I agree with Ramurthy. I prefer to honeycomb even the softest to the hardest nuclei, and you get much better results that way. So femtosecond flax cataract surgery is something that really helps at every grade of cataract surgery, not just only for the hard cataracts. The outcomes are very predictable, and it really gives the edge to both the surgeon and the patient. So from being just a frivolous addition to the cataract armamentarium, I think flax is becoming a tool of necessity.
I think more difficult the cataract, more relevant the catalyst mission. Anyway, thank you all, and I think we pass
One point I want to add. One point I want to add. Nowadays, we have patients with 6'9", 6'6" vision, the soft cataracts. I think femto is definitely a role to play, because the surgery has to be safer, because the patients are coming with good vision. These are NHNT cataracts, neither here nor there. The femto works wonderfully well in these situations.
Thank you, Mohan. And Dr. Pooja is not able to join us. So in her place, Rohit is going to be presenting. He's talking on optimizing ocular surface, too big to miss in premium surgery. It will be an insult to Rohit if I introduce him. So welcome, Rohit. And I'll take leave for a few minutes. I just have to be elsewhere. Please continue.
Thank you, sir. Thank you. Pooja is in Rangachari session, so she couldn't come out of it. So I'll be presenting it on her behalf.
Great.
And thank you, sir. And thanks, J&J, for this session. These are my financial interests. Start off with this concept, old ways will never open new doors. So we have to really look at how we evaluate the whole ocular surface. When we present this slide, it's not always means that everybody should buy everything. But these things are done so that we understand what is really happening. And once we understand what is happening, it's probably easier to make sense of sometimes unexpected problems. See, let me start with understanding the depth of corneal nerves, which is probably the most important thing. These are your subepithelial nerve plexus, which needs to be analyzed with software. You need to understand the proteomics and the inflammation parts of it. There's a bunch of stuff which you can actually see from the tears itself. It's about how smart your scientists can analyze and virtually can pick up everything. And this is a very old slide about how we do all this process. And finally, it's about the power of imaging the tear film itself, which is very important because the tear film actually helps us to understand the optics of the true optics of the eye. For example, this is a point spread function of your tear film from the time the first blink to the second. And if you have a perfect blink, then you can perfect tear film, then it's all in green, which means it's good. And when it's not perfect, then the entire thing changes. That means the vision is fluctuating a lot. So in refractive surgery, if you're looking at two types of patients, one contact lens intolerant, other contact lens tolerant, what we see is more or less both of them have the same kind of metrics, but one has a lot of high OSDI. The question is which surgery you want to do. So that's when we go back to the nerves and we look at, there are three important components which is always in the kind of hemostasis: your meibomian glands, your epithelium, and the corneal nerves. As your meibomian glands are good, the epithelium is healthy, and so is the corneal nerves. As your meibomian glands changes, as it keeps changing with different kinds of dropouts, and you can see that the corneal nerves also keeps changing, and that would impact your epithelium a lot. So how does it really make a difference? How does all these things make a difference to the practice? Because all this would change the way your cornea would heal. And this would change the way it would do after you do a LASIK surgery. For example, you do a LASIK surgery on the first 3 group and do a LASIK surgery on the second 3 group, which is irregular with poor meibomian glands with a lot of epithelial change. Your healing would be completely different. Your nerves would not regenerate the same way as the nerves of a healthy one. And probably this is how an epithelial would heal after you do the surgery. A perfect epithelium healing post-surgery and an imperfect epithelium healing post-surgery is a classic example of what a hemostasis of meibomian glands and ocular surface, which is very important for maintaining the health of the ocular surface. If you lose it, then you lose everything. And that changes your quality of vision. You can see that the perfect, and you can see how imperfect this quality of vision is just because of the change in your ocular surface. Same thing with cataract surgery. The epithelium is very important, and epithelium is a real indicator of how good is your ocular surface. And you can see that a healthy ocular surface from the epithelial aberration, absolutely normal, but here from the epithelial surface itself, we can see cylinders. You do a cataract surgery on them, healing would be different. And you're seeing a diopter of cylinder coming only from the epithelium. It's a very interesting concept. If you're operated on, I did see some fantastic surgery videos of Mohan sir, and a lot of you are fantastic cataract surgeons, but at the end of it, if your ocular surface is bad for your premium surgery and your epithelium itself would induce a diopter of cylinder only on the epithelial surface, then the whole thing beats, just beats the purpose. And when it actually beats the purpose, then you end up in actually having a poor quality of vision and an unhappy patient. So all these things can impact the quality of vision in many big ways. So how does thermal vector pulsation therapy, like a LipiFlow, work in these patients? We use this a lot as a pre-op cleansing, I call it, of the meibomian glands and ocular surface. The heat itself would change the constituents of the lipids, and the massage would help in expressing it out. This is what is been known, and we have studied the cytokines parameters. These are the ones which makes you feel happy, or makes you feel comfortable, or makes you feel irritated. And when you see all these parameters, it shows that cleansing of your ocular surface, or making the ocular surface healthier, would have a huge impact in the health of the eyes as we go on. The speedometer on the right side, which is on the red, shows that all the markers of inflammation are very high to begin with. And after you do the procedure, after 3 months, you do all of them become become completely normal. This is a LASIK patient, 26-year-old, LASIK for 3 diopters, complaints of blurring of vision, unhappy vision. Quantity of vision is 20/20, but quality is poor. The well center, the epithelium is good, everything is perfectly all right. But look at his tear film. His tear film is breaking up very, 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 very fast. And this breaking up fast, in 4 seconds, you're going to see he sees so much of fluctuations of his tear film in 4 seconds that it ends up having a very poor quality of vision. So what do we do? There's no improvement in the treatment dose. That's when we prescribe the LipiFlow. I mean, this is again what we do for post-operations. You can see the same patient who was in 4 seconds having so much of change suddenly drops down to a perfect, healthy tear film. Once you have that perfect, healthy tear film, your drops, what you're giving works, and then you can continue with them, or you can do a home-based heat fomentation and all the other things which we normally do. What happens, we do it before and after, is this is an ongoing study which we're doing. One study is before refractive surgery LipiFlow, other one is post-refractive after 3 months. What we found was when you do a LipiFlow procedure before refractive surgery, or for a patient who has got meibomian gland dysfunctions, the quality and the quality of life is definitely better, and quantity of your tear film, your T-buds, and all that OSDI, which all that complaints what comes with it, completely gets much, much, much better compared to what you do it after 3 months. So there is definitely a favorable way of treating it prior, and all your inflammatory markers also becomes completely different, and you are reducing them before the surgery itself, which gives a very comfortable post-operative period for this patient. These are just the graphs of anti and pro-nociceptive factors, which this LipiFlow can alter. The LipiFlow is just about not taking the glands and cleansing it up. It also cleans and also maintains the ocular surface milieu, and it maintains the balance of things which can cause sensation and which can cause hypersensation. We need a balance We don't need anything to be completely knocked off, but we just need a good balance. And that's what this does. Out of box concept, we have been using it in few patients of keratoconus because we feel that those who rub their eyes constantly, and especially before cross-linking in patients who have lots of allergy, we try to do it, and I've been quite happy. Not that it's a costly procedure, so you can't afford it, can't offer it to everybody, but those on whom I'm going to wait for a few months, or if they're somebody who's traveling out of country, I do offer them, and they're very happy with it. And they say they just stop rubbing the eyes with this, and that's something which is a very important plus point for me. So what does it do? It reduces your itch factors. Once your itch factors goes, the whole necessity to rub goes, and then all that discomfort and other things comes down. And this is a very good example of one of our patients with keratoconus, and you can see that how stable they are, and you can see some amount of flattening also, just because you stopped rubbing and it stabilized the whole cornea. So managing the ocular surface helps in preoperative. If you manage, it helps in wound healing. In post-refractive surgery and cataract surgery, definitely a big role. And I'm trying to work around it in keratoconus also. Thank you.
Thank you, Rohit. That was fantastic. This is something that is the future of all refractive surgeries, be it cataract or cornea-based. One has to understand the corneal surface as well as the tear film and take appropriate steps either preoperatively or after surgery to get the best results. I think the work that you're doing is absolute cutting edge, and that's going to become the norm for everybody. We look forward to hearing more from your lab and from your source. That's fantastic. Any other comments from Virender? Do you have anything to say, Gaurav?
Yeah, I want to speak that for all the premium surgeries, be it cataract or refractive surgery, or wherever vision is the outcome as assessment, means patient wants a good quality of vision, the tear film has to be normal. And this is to be done in primary investigation also. When you are doing for cataract, try to look for the patient is suffering really from the dry eye or not. I may not go for all patients to have a lippy view because of the cost. We are not doing it free. But for the interest, if we feel the patient is not ready, but we are thinking that this will have importance, then we do this free also to the patient, and then we show it that it is better to go for dry eye management first before getting the surgery done. And as I say that it is important for the vision part. Many of the patients we think will not require premium lenses, but once they realize the quality of vision can be improved by treatment, they actually go for premium lenses. The similar is the case for the refractive surgery, because the patient happiness is not by just reading 6/6. Patient says that my quality of vision has to be better. And as we know that after refractive surgery by laser, there is a transient increase in the dry eye. And if you take care of dry eye beforehand, it will actually save him from having the complaints and not getting satisfied. Because at the end, what we want, the patient should be satisfied, not by saying that your vision is good, but we should make him satisfied that he is feeling good because of the quality of vision is good and the quantity also is good. Thank you, Arul.
Thank you, Virender. Gaurav, anything to observe from your side? I think Gaurav is not there.
Can I add one point, Arul?
Yeah, before that, just Rohit has taken it to a different step. Yeah, sure, Mohan.
Mohan, no, I just want to ask Rohit, because we are using the IPL. I know you have the IPL also, Rohit.
Yes.
And you have compared the lippy flow with IPL.
We did the markers what lippy flow actually reduces. You don't see the same thing happening with the IPL. See, ultimately, why do you have a happy patient? Because you're cleansing him up of unwanted markers which are actually triggering up. See, when you cleanse it, it's just not washing, because you can wash them once, but they'll come back again tomorrow. So what happens is the markers which are very specific gets cleansed. Like if you have a panel of 20, you will have around 16 or 17 of them which can be knocked off by lippy flow. But the other procedures just do only 4 or 5 markers. So sometimes you feel their patients are happy, sometimes you feel they're not happy.
That's exactly what I wanted to point out. The level of understanding from Rohit's lab on the tear film markers, the cytokines that are floating around there and how they affect the outcome, how they affect the healing, how they affect the corneal nerves is something that is extremely deep, and that's something that's very, very important.
If I can just, sir, just take 1 minute. Yeah. I do it a lot for my PRK patients. And I realized that because I started doing it because we figured out that there are certain set of markers which are very high in patients with PRK haze or cross-linking sometimes haze. What I do is, because PRK is about removal epithelium and healing, if your ocular surface is poor, it will end up in terrible issues. So we started doing this in a lot of our PRK patients. And what I feel is absolutely that haze, even in 1 in 50 haze, which used to come, has grossly dropped down. Dr. Vinith is here. I even advise this to a couple of my glaucoma people where they have been intolerant to glaucoma medications, because many times the glaucoma medications are filled with your preservatives, because you need preservatives for it to, I think, go inside the eyes or whatever. And many times, for that, I think the IPL will help because, or even LipiFlow will help because you're suddenly making him more comfortable for the drops. And I mean, not for everybody because it's not a cheap procedure, but definitely one way to look at it.
Thank you, Rohit. Now we'll go on to the next speaker. I think Dr. Vinith Ratra is there.
I'm there.
Vinith, thank you for coming in, Vinith. I think you need no introduction. So you're going to talk to us about the standard of care in monofocal cataract surgery. Welcome, Vinith.
Yes, sir. Thank you. Just 1 minute. My slides visible?
Not really. We're not seeing your...
Not visible, Vinith.
Just 1 minute, sir.
Yes, now we do.
So I'd like to thank you, Dr. Arul, for that kind introduction. Thank AIOS and thank J&J for inviting me for this talk. Well, I have no financial disclosures. Let me start with this case. This was a 65-year-old gentleman who presented to the OPD with decreased vision in his left eye. He was a diabetic, hypertensive since 10 years, but was well controlled and was morbidly obese. His best corrected visual acuity was 6/18 N6 in the right eye and was 6/24 N12 in the left eye. His extraocular movements were full. There was no RAPD. He had significant cataract, more in the left eye than in the right eye. His fundus was normal through the lenticular haze, and we advised him a cataract surgery with thickness eye hands, IOL. So on the lens star, we found that on the Hill RBF formula, that he needed around a 20.5 thickness eye hands, and that is what we inserted. The surgery and post-op period was uneventful. Because of the COVID, the lockdown, he came for his checkup 2 months later, and he was smiling and beaming. His best corrected visual acuity in his left eye was unaided 6/6 N6. This is what the eye looked like. So how do we explain this vision? Is it because of the higher order aberrations and the thickness eye hands lens? Well, let me just talk about the thickness eye hands lens for now. This is based on a continuous higher order aspheric surface and is the next generation monofocal IOL, which is otherwise very similar to the thickness one piece in all its other geometry. The difference is on the anterior surface, which has a slightly more, which has a slightly increase in curvature, which results in a better depth of focus, despite it being a monofocal IOL, and gives us this little extra intermediate range. It is this intermediate range which improves the intermediate vision. It gives comparable distance vision to the thickness one piece. And since it has a continuous and smooth change of power, the photic phenomenon profile is similar to an aspheric monofocal IOL. There have been various studies comparing the Technis eye-hands with monofocal IOLs. This one was from the Dr. Grewal Eye Hospital in Chandigarh, where they looked at 116 eyes, in which 71 they had inserted the eye-hands and 45 they had inserted the Technis monofocal. They looked at the distance visual acuity, the intermediate visual acuity, and they plotted the monoocular defocus curve. The defocus curve of the Technis eye-hands was broader and had a larger landing zone as compared to the Technis monofocal. The visual acuity for distance was similar in both the Technis monofocal and the Technis eye-hands, but you can see here that it was significantly better unaided intermediate vision in the Technis eye-hands lens. Ansal et al. Looked at binocular Technis eye-hands insertion with binocular Technis monofocal intraocular lenses. They looked at 64 eyes of 32 patients. They measured the distance, the intermediate. They plotted the binocular defocus curve and also assessed the photic phenomenon and the spectacle independence. The Technis eye-hands provided significantly better intermediate vision than the monofocal IOL, both uncorrected and distance corrected. The defocus curve again had a slightly larger landing zone, and at 1.5, that's at the intermediate distance, there was a one line better visual acuity. They found that 84% of the patients were spectacle independent for intermediate vision. The contrast sensitivity of both the Technis eye-hands and the Technis monofocal were the same, and there was no significant difference in terms of the photic phenomenon, that is the glare and halo. This study by Fidel Vega et al. Was an in vitro study where they compared the 20 diopter Technis eye-hands lens with the Technis monofocal. So at the 2 millimeters, there was a slight increase in the halo, a little lesser in the 3, and between by 3.5 to 4, the halo was the same as a Technis monofocal. What did they conclude? They concluded that the halos were of similar values of energy on the optical bench correctly focused on the core region. The Technis eye-hands is more likely to induce a similar level of photic phenomenon, if any, as the Technis monofocal. So the halos were comparable as measured on the optical bench. When the modular transfer function curves were plotted, you could see that in a myopia, in a 2 millimeter pupil, both the curves were slightly broader. This is because in small pupils, only the paraxial rays are used. The Technis eye-hands also had a myopic shift of around a 0.4 to 0.5 diopter. This is based on the larger negative spherical aberration, which increased the depth of focus. Well, what about visual acuity at far and intermediate? The eye-hands delivers pupil-independent performance that is similar to that of a Technis monofocal for distance vision. What about the effect of decentration? Well, the data on file does tell us that the Technis eye-hands has an equal tolerance to decentration for distance performance as the Technis monofocal IOL. Some clinical points. So what would you generally aim for? Well, it's good to aim for something like a plano to being a little myopic. This is because if you were to go with a little hyperopia, you would lose that intermediate vision. It can be used in all patients in whom a Technis monofocal can be used. It has an astigmatic landing zone of around 0.75, which is similar to a Technis monofocal. So my thoughts are that it's yes, become my first choice monofocal IOL. I have the same chair time. I don't need to explain too much extra to these patients, especially in patients where a multifocal is not advisable, where the contrast sensitivity is reduced, like patients of glaucoma, diabetic retinopathy, and ARMD. The only eyes where I would be a little wary of using them is in patients who have a negative asphericity, like a keratoconus, or those who have had a hyperopic ablation. But over here also, we have to understand there is a slightly larger landing zone, so I just need to be a little careful. and obviously in patients with higher order aberrations where there could be dysphotoxias. The field of vision with progressives for intermediate is compromised. This is due to the hourglass pattern of the glasses, and this is where the Tecnis Eyehance would actually widen the field. I do use a bit of mini or mono, just a 0.25 to 0.5 mono vision, and I do feel that the spectacle dependency is lesser. Even if you were to aim for an emetropia, patients do feel more confident while walking, particularly while going downstairs or walking on an uneven surface, reading a computer, a smartphone, or a tablet, reading a price tag while they are shopping, or even cooking and eating. So, well, how do we refract these patients? Now, the refraction process in these patients is similar to that of a young phakic patient who has accommodation. You would want to prescribe a maximum plus or a minimum minus, since this maximizes both the distant and intermediate vision. The good old retinoscopy is more useful than the autorefractors because the autorefractors use the central part of the pupil to estimate refraction and would not be able to capture the continuous power progression of the enhanced IOL, monofocal IOL. How do these compare with the other IOLs? Well, in this study by Junar et al., they compared the Tecnis Eyehance with the Acris of IQ. There are no studies comparing it with the Vivity still. So both the uncorrected and the distance-corrected intermediate visual acuity was significantly better in the Eyehance as compared to the Tecnis monofocal. With respect to the contrast performance, there was improved contrast, 31% as better in Eyehance as compared to a Clarion, and even better with an XIOL. It's based on the same Tecnis platform, which has a minus 0.27 negative spherical aberration with low chromatic aberrations with a high Abbe number of 55, a refractive index of 1.47. It's not associated with glistenings. It has less capsular phimosis. It's available in powers of around 5 to 34, and the A constant is similar to that of Tecnis monofocal IOL. So, well, in conclusion, we do know that intermediate vision is the need of the hour in our current lifestyles with the laptop, the iPad, the smartphones. The Tecnis Eyehance is the next generation monofocal, and all monofocal patients can be upgraded to an Eyehance. The photic phenomenon is standard monofocal, so it can be a good choice even for night drivers. There is improved functional vision and improved patient satisfaction, which is achieved with the Tecnis Eyehance because of the reduced dependency from spectacles for intermediate vision. Well, thank you.
Thank you, Vineet. That was very nice. I think most of us are very happy with the Eyehance. Kumar, are you using a lot of Eyehance? Do you have something to say about this? Because I'm thrilled with this product. I'm so thrilled that I think that all monofocal patients should be implanted with Eyehance as of now.
As per now, actually, this is a lens of choice for my own eye. So I've seen the results. I'm very happy. I don't have toricity, so I'm quite happy. I'm only a little surprised why are they taking so long to introduce an Eyehance toric? If they introduce that, the Tecnis 1 consumption will become zero. So I'm hardly using any Tecnis 1, you know, and the moment they introduce the other one, I'm sure the other one will also become zero. So even if the patient has a drusen, I put Eyehance, except for any other contraindication of toricity. Otherwise, I'm still using only Eyehance. So I think it's a lovely lens.
A fantastic product. Gaurav, I think he's not there. Virender, would you like to say something, please?
Yeah, I agree with Kumar that this is the lens of first choice because some patients, my first choice is a multifocality, but those who are thinking that the glare should not be there at all, Eyehance is the only option. And I will share with Dr. Vineet as first of my patient who got Eyehance and was having 6.6 and 6 was a post-LASIK, post-biopic LASIK patient. And I was surprised that why other one not reading, but why he is reading 6.6. So aberrations definitely play a positive role in cases, particularly post-operative surgery. So my first advice that all LASIK patients who have undergone myopic LASIK, the Eyehance should be the first choice because multifocal is a contraindicated or not absolute contraindication, but relative contraindication. And these patients don't want to use glasses because they have been without glasses, post-LASIK for many years. So IONS is the first choice in them. And another thing, all the ladies also, even the housewives, they feel very happy that the kitchen work becomes very, very comfortable for them without glasses. So IONS is one choice. And I prefer doing kind of monovision, the other eye, one eye ametropia, other eye minus 0.5 or 0.75, that almost gives full range of vision. So IONS is definitely a big advantage. And the biggest advantage of confidence that using Technis One for years, not having any of the complications. So because of having the same platform with added advantage of intermediate vision, IONS is the first choice in monofocal, and otherwise my first choice now is Synergy.
Thank you, Virender. You're a man after my own heart. I believe that the first choice should be a trifocal followed by IONS. I think you mirrored exactly my thought process. So everybody should get clear vision over all distances, and we need to choose the best lens that would suit. The advantage of IONS again is the cost difference is minimal, so one can actually push patients to take it up without too much of an effort. Any other observations?
But I think Kumar is saying good that if they come out with a toric lens,
yes,
then the toric IONS, and they can then actually sell it at the cost of the Technis also.
Yes.
So that will be a good advantage to
also if they can make it preloaded.
Yeah.
Arul, if they can make it preloaded IONS, it'll be very good actually.
All lenses are going to become preloaded sooner or later.
I know, but IONS
every
also
single lens on the market.
But I struggled with the Technis One preloaded. It was damn irritating because you had to wait 30 seconds, then 20 seconds, and then this and that. And that's why it never picked up. I don't know how many of you have used the Technis One preloaded.
Better technology.
No, I'm talking about the iTech. I've used the iTech. iTech, Kumar.
Yeah.
Very unhappy.
Yeah, I think preloaded needs some betterment. But lens-wise, I think C and IONS is going to change the market. Because the patient happiness is really, really different. And I don't know how many of your patients are complaining of glare. My patients are not complaining for glare. I do one thing, that you will have some glare, but you will have a good vision for distance and near or intermediate one with the Synergy. Then patient does not come back with a complaint. If you don't tell them like this, then they actually say that I am getting good vision, but there is some glare. So you have to say that you will have some glare, but you will get good vision, or you want no glare, but not a good vision for near. So then they say, yes, acceptable. So I think that also is a thing that if you tell them beforehand, they don't feel cheated or like deceived. Otherwise, they say that you are now trying to say to satisfy me, which I'm not actually understanding. So my choice is that.
Yeah. Excellent observations. I think, shall we pass on to the last presentation?
Yes, Ramurthy, welcome back.
Welcome back, Ramu.
Yeah, thanks for holding forth. I think it's our pleasure to welcome Dr. Bobby Yang to present us about help patients seeing at their ideal distance through CRV technology. I thought we were having a very relevant and excellent discussion, and what Bobby has to say will gel in very well with what was already being discussed, and we'll carry it further after his presentation.
Hello, everybody. Hello to my friends in India. I hope we see each other soon. I'm here to share my experience with the Synergy, and let me share my slides. Okay. Good afternoon. I'm presenting my talk on helping patients see at their ideal distance to the CRV technology, or continuous range of vision technology. I'm an investigator and consultant for Johnson & Johnson and other IOL companies. So as the talks go, we see that there's just so many IOLs in the market now. And it's actually very confusing and intimidating, even for our residents and fellows when they graduate. What lens will they use? In this category, I think the Synergy falls closest to the trifocal category. So the first innovation in diffractive technology was the bifocal, where one step height was added, and this gave patients good distance and near, but many patients complained of photic phenomena. The second innovation was adding two-step heights, so trifocals came about, and there was intermediate focus at 80 centimeters and near vision at 40 centimeters. What was lucky for us is the patients complained of less photic phenomena. There was another mini innovation wherein quadrifocal was created, and when they did this, they realized that redirecting one part of the intermediate vision to distance augmented the distance, and they left the intermediate vision at 60 centimeters. So now these are our innovations in trifocal technology, and these are the lenses that represent these innovations. So we did the comparative study on the three trifocals that were most popular, and what we found was the defocus curve shows us that distance vision was good, near vision, so there's a peak at distance, there's a second peak at near, and the trifocal somehow smoothed out the intermediate vision of these patients. So EDOF now came about, and why did EDOF come into the market? Because patients wanted more range of vision with the monofocal, but they wanted less side effects from the trifocals or the multifocals. So extended depth of focus lenses became more popular. So we also did the comparative study on three different extended depth of focus IOLs, the Symphony, which is a diffractive lens, the IC8, which is a pinhole, and the WIOL, which is a polyfocal. And we found that distance vision is perfect, intermediate vision is very good, but near vision is somehow not enough for the patients because patients wanted J1, but they can get only J2 to J3. So now, the new kid on the block is the technique synergy, and we wanted to showcase how it provides continuous range of vision. So that synergy is actually a combination of the advantages of two very good products from the Technis family. The Technis multifocal provides very good distance and near vision, while the Technis Symphony, we know, provides very good distance and intermediate vision and has some features that increase contrast sensitivity. So the defocus curve now of the synergy, as we see here, smooths out the gaps or dips in the trifocal lenses. So one feature that I like about the synergy and the Symphony is the improved contrast sensitivity. So how does it do this? First, the Technis family has a negative spherical aberration which counters the corneal spherical aberration positive, essentially making the total optical system near zero in terms of spherical aberration. The second feature of the Technis family is the high ABI number, which helps chromatic aberration compensation. So if you see this table, you will see that the Synergy and the Symphony have the highest ABI number of all the hydrophobic acrylic lenses. Another feature of the Technis diffractive lenses is chromatic aberration compensation. So with the diffractive optics, sharper focus is achieved because the dispersion of the red and blue light is reduced compared to a standard monofocal or typical IOL or even a refractive IOL. This reduction in dispersion of colors aids in sharpening the focus. So we were lucky to be part of this prospective randomized multi-center study featuring the Technis Synergy and a very good trifocal IOL, and we are presenting 3-month interim results. So our study was a prospective multi-center bilateral implantation, randomized 2-to-1, meaning for every 2 Synergy recruited patients, we recruited 1 Panoptics patient. We are presenting 177 patients with 3-month follow-up. So in this graph, we see that the defocus curve of the Synergy is in maroon or red, and the Panoptics is gray. All throughout the defocus, the Synergy performs better than the Panoptics, all throughout the defocus range. Another interesting feature is the near vision range. So in this graph, we show that at 3 diopters defocus, 3.5 diopters defocus, or 4 diopter defocus, the Technis Synergy performs better. So for those of you who have experienced Synergy, we know that the near vision is excellent with this lens. the range of vision is very good, and we see in this graph that at far vision, synergy is better. Intermediate vision, 66 centimeters, synergy is better. Near vision, 40 centimeters, and near vision, 33 centimeters. So all throughout the range of vision, synergy performs very well. So what about dim light? So in mesopic, best corrected distance vision, mesopic near vision, and photopic low contrast vision, the technique synergy outperforms the panoptic. So we know that patients want good nighttime vision, and the synergy delivers this better than the panoptic lens. So in terms of patient satisfaction, so we have a questionnaire that we gave to the patients, and 90% satisfaction in seeing reading street signs at night, 96% satisfaction in reading the menu in a dimly lit restaurant, and 97% satisfaction in seeing steps or curbs in the evening. So we want the patients with synergy to be seeing very well in nighttime activities. So in summary, the technique synergy provides a wider range of continuous vision. That's why we call this a continuous range of vision lens, a new category. And binocular visual acuity from distance to near is better head-to-head compared with the panoptics. Near vision is as good as the technique multifocal with a strong intermediate vision. Or you can say the near vision is better than your usual technique symphony lens. And one important feature of the synergy is the high image contrast. As we know, diffractive optics sometimes sacrifice contrast vision, but because of the high Abi number of the technique material and the chromatic aberration correction of the diffractive optics, plus the violet light filtration, the technique synergy delivers high contrast vision. Thank you very much, and I'm here to answer questions.
Thank you, Dr. Bobby, for that very extensive coverage. As you rightly pointed out, this is what struck me also. Whenever we started talking about symphony, about panoptics, about the other trifocals, near vision, we even started talking about it only from 40 centimeters, 60 centimeters. I was truly missing those original diffractive multifocal lenses, the +4 diopter lenses, which Technics came up with. They're excellent for near. You can't talk about intermediate with those lenses. But, an 80-year-old could just pick up his newspaper and read. And today, I think Synergy is something that's offering us that ability, where it's not about 40 centimeters, it's right from 30 or 33 centimeters. Even a 5-footer's arm length is where they can hold their newspaper and read right up to infinity. I think it is that way this lens scores over the others, apart from the quality of vision and other aspects. As far as I can see, the entire panel, they're all extremely experienced multifocal surgeons, and all of them have enough experience with Synergy. Would be great to hear their thoughts. I see Mohan first on the photograph, so maybe we start with him.
Able to hear me, Ramu?
Yeah.
My lens of choice nowadays is monofocal plus, that is high-ans on one side. On the other side is Synergy. Okay, and if I have a very, very rare patient of a high myope, very old patient who wants just read, I use a Technics multifocal +4 in one eye and +3.25. But by and large, I've completely switched over to Synergy simply because the photic phenomenon is less, the contrast sensitivity because the high Abbe number is much better, the range of vision is much better. People are able to read at 35 centimeters, 50 centimeters, work on the computer, intermediate distance. And I operate on many of the golfers in Chennai, and many of them I implanted with Synergy lenses. They're all very happy playing golf because the putting is fantastic for them, and the golfing game has also improved much better after the Synergy lenses. So this is just to give you an example. And also High-ans is another very, I think it's a fantastic lens. And people who don't want to have even the photic phenomenon take that risk. High-ans is a monofocal plus lens, which is really a great tool to have and in your armamentarium. So these are, I think, my take-home points.
Virender, I mean, would you like to talk anything about mixing and matching these lenses. Right now, Johnson & Johnson has provided with us an entire array of lenses, right from a single piece to monofocal to multifocal, diffractive multifocal, then Symphony, Synergy. When are the occasions that you put two different lenses in the two eyes?
Yeah, for multifocal, I am doing since 1996. And as you say that we have used refractive, now diffractive, and the diffractive with +4 addition, patients were very corneal. I was very happy with the +3.25 add also. And many of the patients who got one eye done before Synergy was introduced, now I am implanting Synergy in the other eye. And they are not feeling any complaint, but they are feeling a positive thing that what they were missing for intermediate part or continuity is now being restored. And with that, they are very happy. And as you said that we have done mixing for monofocal part also, I prefer still not to do monofocal in one eye or Synergy or Ions in the other eye, Synergy or Symphony in the other eye. But some patient I have done for the vision, they said that I'm not very happy with the quality of vision in the one eye because the vision was 618 or 624 because of some other reasons. They said that we want the independence from glasses. So in those cases, I implanted multifocal or Synergy in the other eye, and they are also very happy. And I don't know what is your experience, but my majority of the patients are now not complaining of night glare with the multifocal or Synergy lenses. Probably now their acceptance from the peer group is also very good. Initially, they used to ask their friends, are you seeing glare? They were saying no. But now I have many friends done surgery for the same lens. So when they ask that, they say, there is some glare, but I am able to get good and freedom from glasses is better. It is there. And mixing and matching, I think it is going to make a big difference in the all patients in whom some other multifocal lens was implanted, bifocal or trifocal. If you add Synergy with them, they go in gel and glare is not making difference feeling in their eyes.
I think it's a very important point that you have made. Just like in refractive surgery, we have PRK, LASIK, SMILE, but all are mature technologies now, and one potentiates the other. Similarly, though it's a Johnson & Johnson platform, even the trifocals that we have today are very mature platform, and the kind of problems our patients have had with the earlier refractive multifocals, the +4 diopter multifocals, the quality of vision, etc., is going away. So overall, and the fact that we are able to address toricity also with most of these lenses, I think the uptake of these multifocal intraocular lenses and the word of mouth, a good word about these lenses is fast spreading. I think it's for us to go ahead and take up this market. Your thought, it's Arul?
Yeah, Ramurthy, this from the diffractive bifocal lenses, which left something to be decided in the intermediate region, the trifocals came in to give you better quality of vision and better distancing. But now the continuous range of vision lenses or the hybrid lenses that are coming in are the future, because they bring down the photic phenomena to a lower level while maintaining the distance correction over all distances, as well as give better contrast sensitivity. So I think Synergy meets all this criteria as of now, and I'm sure that J&J would come up with even better modifications. So as of now, just like Virender said, my choice at one end is going to be the IHANS for monofocal, which is replacing my monofocals. I prefer to put in Synergy for all patients who choose to have multifocals done. Limiting factor would be the cost, and those who are not able to pay that extra, I put in the Technis 2.75 in one eye and 4 in the other as a mix, where you get the range of vision. But Synergy is fantastic. Whatever it promises, it kind of over-delivers, not just delivers what it promises, it over-delivers a little beyond that. So I'm extremely happy with that lens.
Gaurav, I want a slightly different comment from you, in the sense I know you have a huge refractive as well as a cataract practice. So if earlier LASIK patient of yours comes to you and asks specifically for multifocality, is quite insistent on it, what are the aspects you will think about, and what's your lens of choice?
Okay, that's a very, very difficult question to answer. If I'm not, if I don't want to. Yeah.
I requested Gaurav. I mean, I think.
Oh, I'm sorry. I heard it as well.
Sorry. Even I didn't catch that. I'm so sorry. Okay. So thanks for asking me, sir. And today, I would not be reluctant to use eye hands in these patients, of course, but when using a multifocal lens, I would have to, choose a lot of considerations, and I would definitely want to ensure that, the patient has a very well centered ablation and look at, the many prerequisites that you would have to. So I don't do too many multifocals on my post-LASIK patients typically, but yes, if somebody had a very nice, well-centered ablation and a very clear, so biometry, the good thing is that, now in post-LASIK patients, we can do excellent biometry. So our, ability to provide emmetropia has improved a lot. So that is one thing which has improved over the last few years, that we can now have good IOL prediction and offer them close to emmetropic outcomes even post LASIK. So that has improved the chances that we can actually offer multifocals. But I am not over enthusiastic about using multifocals at all in these patients, because I have burnt my fingers in a couple of these. That said, I think Synergy has really improved our situation. One area where I felt that it stands out amongst the other generation of lenses that I've used, that even the other trifocals, is that in the past I had to tell all my patients that you have good light whenever you want to read. I had to always tell them that you'll only be able to see well at near. Now with Synergy, somehow I'm noticing that that thing is not as important to patients. It still is important because it still divides the light into so many things. But this is one big area where I think I find Synergy has changed the game for some of us. Yes.
My thought process was, for a long time, putting a multifocal in a post-refractive was a strict no-no. But Symphony came and to some extent changed that, in the sense that many of us were a little confident about putting in a Symphony. If otherwise, the cornea was reasonably healthy and the patient had good quality of vision subsequent to the refractive surgery. Since Synergy is something built along the platform of Symphony, the patient is more demanding about the quantity of vision. Should we be considering Synergy? Anybody has any experience on that?
I've done it, Ramurthy. But the only thing is, as long as you're able to get the formula right and your power right, which is possible nowadays to hit the bullseye consistently, then you can do that. I've done it in a couple of post-LASIK patients with Synergy as well as Symphony as well.
Symphony, all of us have done.
Symphony, yes, Synergy also, and they are all doing very well. But you need to be the very bang on target on this.
You have an experience, Bobby Ann, on this using on post-refractive cases Synergy?
Not yet. So one thing that we learned from the study, and I'm sure the faculty knows, is that because of the big, wide range of vision, and because it's very good at near, if you miss, we want to veer towards the hyperopic miss and not towards the myopic miss. So that's something that the Synergy gives us in terms of luxury, is that you have a wider range and you want to be in a direction of more hyperopia than myopia.
Absolutely, sir. I fully agree with you.
Amma, can I add something?
Vineet, I want a slightly different kind of a comment from you. Most of us in the panel are busy private practitioners, but you represent one of the biggest institutions. And most institutions were a little wary of taking up these multifocals for a long time. Is the scenario changing? How is it now? What's your experience?
Me, Ramamurthy?
You have to unmute yourself. Vineet?
Vineet.
Oh, sorry.
Sorry, yeah. So no, not much. It's still the monofocals which are what we generally use, the eye hands. The monofocal plus is really picked on. So that seems to be the major lens. And until a patient generally asks us for a multifocal, we don't. But yeah, for me, if a patient does ask me for a multifocal, Synergy is the first choice. It used to be Symphony. It is now shifted over to Synergy.
So first, we guys have to teach you to use the lens before we talk to the patients.
Huh? May I add?
You had the first. Okay, Virinder, a short word from you.
Yeah, I have done the Synergy post-LASIK patient in a doctor she is a gynecologist, and she is having only one eye done. One eye nucleus started, and she wanted freedom from glasses again. So I had done Synergy almost 2 months plus, and she is very happy in doing surgeries now.
Great. So we started with you, Kumar. You had the first word. You can as well have the last word.
Thanks, Raman. The point, what was surprising, yes, I've used a lot of symphonies in post-refractive. I've used synergy, patients are happy. Patients are also happy with symphony and Technis multifocal mix and match in post-refractive. But what is even more surprising, if I tell you, a patient who has had hyperopic LASIK, technically is a contraindication for a multifocal. I've used symphony and patients are happy. So what is textbook telling you and what we experience in real patient life? Before I did my first hyperopic patient and I put in a symphony, I called up a few people and they all said yes, no, yes, no, yes, no. But I did go ahead with the patient and patient is extremely happy. The mind adapts much more than what our textbooks tell us. So yes, it is a contraindication, but it works beautifully.
I think, we should also be wary of these anecdotal experiences, because one patient obviously with a hyperopic.
I have at least 6 eyes of hyperopia and pre-op, post-op, full data and patient being very happy.
Okay.
Good.
The lady is already there to throw us out. And so thank you. Thank you so much. It was a wonderful learning experience for me and a great show put together by the speakers and the super group of panelists. And thanks, J&J, for getting this together. I really hope the delegates who joined us also benefited. Thank you all.
Thank you, sir.
Thank you, everyone. Thank you.
Session.
Thank you.
Thanks.
Excellent and insightful talks by all our speakers and beautifully moderated by our moderators and panelists. So, ladies and gentlemen, with this, we come to the end of this session. Let's have a huge round of applause for all of us who are present here. I'll request all of you to please unmute your lines and switch on the camera in case it's off. So let's have a huge round of applause, and I request the AV team to please take a screenshot of this session. Amazing, great.
Big round of applause to you.